go on to our next speaker, Dr. Pradeep Sharma, who truly needs no introduction, who was the head of the RP Center of Ophthalmic Sciences in Pediatric Ophthalmologist, Neuro-Ophthalmology, Oculoplasty, and now is the lead person in these departments in the CFS group of hospitals based in Delhi. And he is going to be talking on evaluation and treatment of nystagmus, preferred practice guidelines.
Thank you, Dr. Chitra. I would like to thank you for including me in this really select group of people. And we are going to talk about preferred practice for evaluation and treatment of nystagmus. Nystagmus, as we all know, is a rhythmic regular oscillation of the eyes. And we know that we are going to deal with physiologic, pathologic, and nystagmoid conditions separately. The physiologic nystagmus, we are all aware of optokinetic, vestibular, and voluntary nystagmus. Coming to the basic group, which we will be mostly dealing with, the nystagmus in children, which will be in these three categories. The sensory nystagmus, in which we need to do an eye examination, fundus, ERG, and VER. The second group is the infantile nystagmus, fusional maldevelopment nystagmus, and nystagmus blockage syndrome. Here you need to do an extensive eye workup. The third group is spasmus nutans, seesaw nystagmus, and vertical nystagmus. In all these three, imaging is mandatory. So the first one is sensory, in which there is a pendular nystagmus. Here we should suspect ocular problems, visual problems. So do a proper ocular examination of the retina, fundus, ERG, and VER. The second group, which was earlier called as motor or manifest nystagmus, these are bilateral conjugate nystagmus happening in early childhood, and they have evolved in three phases. Infancy, they will be having side-to-side movement, and later on they have a head posture. So that we should find out which way is the head posture, and if there is a head turn, then we should distinguish an adduction null from an eccentric gaze null. Now, how will you know this? If you cover the adducting eye, if he has an adduction null, then it would shift to the other side, whereas an eccentric gaze null, he would continue to have the same. Now, this individual child, if you see here, now he is having the right eye fixing. You cover this eye, gradually he will just turn his head to the other side. So this is a must, and this distinguishes a basic thing for your surgery. The manifest latent nystagmus may have associated strabismus, and in these cases you should know that they may be IDS or an infantile esotropia. Correcting the squint itself is in a way a great step in the correction of nystagmus. Examination of nystagmus, so look for the head posture for distance and near both. It may vary, so periodic alternate nystagmus should be kept in mind. Associated squint should be looked for, and any associated condition like albinism should be looked. So the important points in nystagmus, AHP, the type of nystagmus, whether it's pendular jerk, right beating jerk, or left beating, or up and down beating jerk. Is it increasing in abduction gaze? Is it increasing on occlusion of either the right or the left eye? Visual acuity you need to assess little differently, binocular as well as monocular, not just routine monocular that you do. If you assess the binocular visual acuity and you find that the vision binocular is much better, you need to reassess your ocular vision after not just covering with occluder, but with a +4 diopter in front of the other eye. Associated strabismus should be looked into. Any associated ocular condition like albinism, any other problem like whether it's an unilateral or asymmetric nystagmus should be known. If there is a face turn, measure it with the protractor or the protractor app on your smartphone. And always watch for periodic alternate nystagmus, which means you have to examine the child for consistent 5 minutes. Spasmus nutans you will pick up when a child is having a torticollis with a head turn and a disc jugate nystagmus. So if there is a unilateral or asymmetric nystagmus, keep in mind it may be spasmus nutans, and you need to do an imaging, and you will pick up life-saving conditions. So imaging is a must. Any nystagmus which has oscillopsia or acquired, you need to do an imaging. So as a rule, you may have different conditions which are causing it, but you need to do that. Then there is a nystagmus blockage syndrome which you may encounter, where you will see an inverse relationship between nystagmus and esotropia. Here you will do a surgery according to that. So how do we manage them? We have to do an optimal prescription, use of tinted glasses. Contact lenses do not have any extra control on nystagmus. Prisms base out may help control on nystagmus. Auditory biofeedback and acupuncture do not have any lasting effects. So this we have studied and we have found. Medical treatment in the form of baclofen for acquired pan has worked, but nothing else. Gabapentin has also been used, and brinzolamide has been mentioned by some people, but it doesn't have much role as far as that. Surgically, yes, they are very gratifying results in correcting the head posture if there is an eccentric null. Artificial divergence surgeries may also help by inducing the divergence. And whenever there is a surgery to be done, the preference for us is augmented Anderson's for up to 30 degrees, like this case, and MR recession of 9 and LR recession of 12 yields the results. If there is a periodic alternating null, you have to do a bilateral augmented Anderson's or a bilateral horizontal recti, supramaximal recessions. Eccentric null with strabismus, you correct the nystagmus on the dominant eye. So always find out which is the dominant eye, because doing a surgery on the non-dominant eye for nystagmus will yield 0 results. And strabismus correction can be done on either eye. If there is a head tilt on or thing, then the surgeries would be on the oblique muscles. Finally, I would come to this conclusion that nystagmus in childhood, you need to investigate if there is a sensitive nystagmus for eye examination, fundus and ERG. For the other infantile nystagmus, fusional maldevelopment, you need to find out the AHP and the type of nystagmus. And again, spasmus nutans, seesaw nystagmus and vertical imaging is mandatory. This will save life. And these are the take-home points for the surgery, that you need to do which type of surgery. This will tell you that cases with definite eccentric null up to 30 degrees, they respond very well to augmented Anderson's. More than 40 degrees, resections on the opposite muscles have to be added. For PAN, you do a bilateral augmented Anderson's. For fusional maldevelopment nystagmus, correct the squint, that will correct the nystagmus itself. And for the IENA, again the same, no definite null, nothing much can be done. Imaging is a must once again. Thank you.
Thank you very much, sir. Excellently covering a very difficult topic very precisely and on time. Just a word on, if you can, sir, on nystagmus with no face turn. So, your experience in the Hurtle-Delosu or all 4 recti recessions.
So as I said in the last conclusions, when there is no eccentric null, we can try anything and everything. Nothing seems to be working till now. Whether it is a medical treatment, whether it's an acupuncture, or it's the Hurtle-Delosu procedure, which we have published compared with the full supramaximal recessions. Right now, nothing yields results more than 3 months. You may have a satisfactory thing for 3 months, and then the patient will come back to you or somebody else. Thank you.
And one more question can I
Yes.
ask? What is the ideal time for doing surgeries for face turn?
Correct. I think that is a very good question. So, because the head posture gets established by about 3 or 4 years, so don't be in a hurry to operate before 3 years. Around 3 or 4 years before school going, you can correct these nystagmus with an abnormal head posture.
Thank you very much, Dr. Pradeep Sharma, for an amazing talk.